run about till 10 till today. I'm running as quick as I can through it, giving you the information that you need. You know, I'm still in amazement. It's week 6. We're halfway through. Next week, I'll be turning on the subjective grades, and I'm going to leave it there up till about week 9, 10, and then I'll turn them off again. This is just to let you know how your subjective grades are, you know, working with your objective grades. Remember, the objective grades must be a 78 before we add in subjective grades. But, you know, this class is doing really well. Your grades are really good. So thank you so much for that. And shows me that you're really trying really hard. Calculate with confidence is due. It is a, in your Calculate with Confidence book, it's pages 699 to 709, questions 1 to 61. And many students say, well, how do I submit it? You can do a paper and multiple uploads, because there is multiple uploads allowed on this. So it's not like you have to have just one, okay? So if you're doing it on paper, that's fine. There is a handout. I'm going to be looking to see and send it to you also. I know that Professor Morris had one, so I'm going to be sending that to you if you can't find it. Quiz 4 is due by Sunday. And you will notice that the congenital heart defect and cystic fibrosis case studies, I had to reset. The dates that were put in there were not correct. So if you've done them already, it's going to show like your to-do list, like you haven't done them, but you're going to see the grades in the grade book. I made sure the grades I personally transferred to ensure that. So if you're seeing that, don't be confused. It was just that some students wouldn't have the ability for 1 week late to be able to get them in. So I was proactive and did it now. Okay, so don't get upset. You know, if they're done, they're already done. There are NCLEX questions due this week, and we do NCLEX questions the week before always exams are due. It's just to give you into that routine of asking questions and seeing if you understand them. So that's why NCLEX questions, that's where you'll see them. Now, next week is exam 2. I think you guys are going to be pretty well prepared between your lectures, your PowerPoints, your Kahoots that I give out, because those Kahoots have all your concepts in there. And then you do have the reviews. Now, Professor Morris has already done a review, and I've already posted it on the page. And you will see me just refresh that one page so you have one place to look. I can't stand to have it in 3 different places and where to look, and between all the classes, you don't know where it is. So it's one announcement. You'll see me putting all the reviews, and I also attach the PowerPoint for that, for your study guide. Remember, next week, come in a little bit early so we get you set up, and there will be class afterwards, and I will be doing a Kahoots. I know last exam I wasn't feeling well, but this week, next week, you will be getting me to do a class afterwards. Usually I tell you to come back at 4:20, and we go right to 5 o'clock to get that done. Now, the project, it's a clinical assessment project, is due on June 5th. And most students like to get a quick, head start on it. It is not overwhelming, but it's something that I want you to have fun with. If you know a child, yourself, your daughter, your son, your brother, your aunt, your uncle, or something has a diagnosis that can be perceived as a pediatric diagnosis, could be Down syndrome, could be asthma, could be reflux, could be cystic fibrosis, juvenile diabetes, all of those things. Whichever one is near and dear to your heart, I suggest you do that, because then you get something from this project. And it's 3 parts. One is just a 250-word APA paper. Tell me about the diagnosis. What is it? What is it all about? What is cystic fibrosis? Only 250 words. Please, 2 references, okay? Please give me 2 references. The second part is an assessment form, which is already on your modules, but I'm going to send you the Word document, okay? That will be sent to you because that one is a PDF and it's hard to work with. and hard to write on. So I will be sending that to you. And then the third part is you teaching a child, teaching a parent, or I've actually in real time have taught nurses on different diagnoses that we've never seen, and students chose them and they presented it in when we were doing real clinicals before COVID, would give them a little session on what is that diagnosis and what to look for, how to prevent it, how to teach parents, how to teach children, and then as a nurse, what are the things that I need to see or what's happening so that they can understand their children better. And that was actually a lot of fun. And I actually miss going to clinicals and having my students doing this project and then presenting it, some of them, to these parents. So anyway, the project, that teaching part, most students will choose a PowerPoint. Don't go 20, 30 slides. I'm not looking for that. Give me 5 well-formed slides on some sort of teaching. Could be asthma, how to use the puffer. You've already started that, using that in your discussion question. Or it could be gastrostomy tube feedings, how to run a tube feeding, because you're all about talking about a child who needs a gastrostomy tube, like Pierre-Robin syndrome. So whatever you want to do, just 5 little slides and just teach me something that I need to watch out for, or how to do, or how to prevent. Okay. So make fun with it. All right. I've had some students pick some really personal things, and I think that's pretty cool. And I'm really excited to see. Remember, shoot me a message. I want to know what you're doing. Okay. To make sure I don't have 100 asthmas. Okay, because that is a popular subject. So make sure that you check with me, and if you're one of the first 5, you get it. After that, it's too many asthma. I think I know a lot about asthma now with the amount of information I've given. So today, what we're going to do, week 6, wow. We're going to go over chapters 43, 44, hematologic and immunologic dysfunction, and children with cancer. And we're going to go over some of those children and cancers and what they are. So that's about that. Any questions? So can the people off camera, are you there? Because I have nobody who asked me that they're driving. That's all I say. Are you there? Are you Juliet, Hannah, Grace, Shania?
Yep.
Dial, are you with me?
Yes.
Okay, I'm just making sure you're there and that you're a part of this. So again, we're going to go over the PowerPoint first, and then we are going to go into the Kahoots. And are you enjoying the Kahoots? Are they helpful for you? Isn't it great to be tested right after you hear information and say, oh, I remember, what did she say? And trying to figure it out. I mean, most students tell me they do, so.
I think they are very helpful.
Good. That's what I want to hear, because, I do take time making them. And every single quarter, I change the Kahoots. There's something new, something added, some subtracted, and it has to do with what the exams are about and then what the HESIs are teaching. I do this gap analysis, which shows me those concepts that students miss. So I'm always infusing new concepts in there to help you so that you can do the best you can do, okay? So hematologic and immunologic dysfunction. Well, when you talk about that, number one is a history physical. What's going on with this child? Many times you'll see the hematologic, it's that they don't have any energy. They're, used to be full of energy. They're taking naps, and that could say, all right, let's do a complete blood count. Could be a low hemoglobin hematocrit, some sort of anemia, which we'll be discussing. It could be bruising. It could be nosebleed, so many things. Now, we know that iron deficient anemia, usually in children, is due to poor iron sources, and their nutrition isn't what they should have, because initially children are given mom's total body, immune system and, whatever their blood levels are. but they do not make their own cells till about 4 to 6 months old. And then they start making their cells. And then if we're not getting proper nutrition, how will we maintain that hemoglobin hematocrit, which does carry oxygen and iron around to the body? The immunologic, you talk about infections, and they're frequently, it's telling you the immune system's not where it should be. So red blood cell disorders, most common anemia. There's many sorts of anemia, and we're going to go into them. But basically, it is just a low hemoglobin hematocrit. And think about what a hemoglobin does. The hemoglobin carries oxygen around to the body, so it gives you energy. And it also gives you that iron, which gives you that strength and endurance. So if you are fatigued and tired all the time, I can guarantee you probably that hemoglobin is really low. And that's what the cause, because you don't have all of that nutrition of the body feeding it. We in children think that low hemoglobin is less than 10. In adults could be a little bit higher than that we're starting to consider anemia. So there's 3 different types of anemias, whether it's a decreased production of cells or an increased red blood cell loss or increased blood cell destruction. And there's many diagnoses, and these are in your book, this big chart here. So decreased red blood cell production, many of them have the same type of symptoms, okay? Whether it just means that your red blood cells are low. So you'll see, all of these different symptoms, but let's look at the nutrition deficiency. Number 1 common anemia is iron deficient anemia. Many children have it, many adults have it. Due to many different reasons. And the other one is that B12 or the intrinsic factor anemia. Again, it is nutritional. We also had that bone marrow failure. That means the bone marrow supposed to be producing these cells are just not doing it. We see that in aplastic anemia. Now, aplastic anemia is not curable, and it is a deficiency of all components of the blood. So that is something that this child is going to be needing transfusions probably and other things. And we're going to go into that in a little bit later. Also, if you have acute lymphocytic leukemia, you're going to see that the bone marrow is not working. It's producing immature white blood cells, and it's just not doing what it should do. And you're also going to see decreased hemoglobin hematocrits also. Increased red blood cell, it's a loss. It's whether it's you're bleeding out, okay? And we look at that red blood cell loss. Many children who never knew they had a bleeding problem come into the doctor or into the emergency room. They're having multiple nosebleeds, epistaxis. Why is the nose bleeding? Well, you had an upper respiratory, okay, send them home, put your nose, little Vaseline, keep it as moist as possible, but then it continues and continues. At that point, we'll be doing the CBC, just a simple CBC to start with. And of course, with bleeding, you do that blood panels of PT, PTT to look at that too, if it's a bleeding coagulopathy. Now there's something called, we know hemophilia is a lack of a factor. We're going to go into that. But ITP is idiopathic thrombocytopenia purpura. Now think of the P. P is platelets, okay? Decreased platelets. We know we need platelets for clotting. If you don't have platelets, you're going to bleed. So ITP is another diagnosis that you're going to see that you're going to need to understand. And then DIC, very complex disease. I'm going to mention it. You don't have to know it. It is a multi-system, usually due to overwhelming sepsis. If you have a child in the ICU, where they'll definitely be probably the sickest kid on the unit, because you are giving blood products and heparin and monitoring outputs and bleeding and etc. So I'll go into that a little bit. Then increased red blood cell destruction. So you have cells, they're made, but they're dying really quick. So number 1, sickle cell anemia. Sickle cell anemia is those sickle-shaped cells, but they die quickly. So what do you see with sickle cell anemia? kid comes in sickle cell crisis, they're going to be in pain, they hurt, whether it's the chest, the hands, the feet, the knee, the shoulder. There's somewhere that they have, sickled and had this crisis. But you will always see hemoglobin hematocrits very low. Many of them require blood transfusions in the emergency room, even before they get upstairs. I think the highest, the highest sickle cell anemia blood I saw was 7 and 21. And I've seen it as low as 4 and 12 hemoglobin hematocrit. And of course, that one was urgent to get that blood in as quick as we could. And then we look at the thalassemia. Now, thalassemia is a blood that's born almost like in a rectangle, squarish shape. But the problem with thalassemia, they burst really quick. Now, the problem with these cells are homolyzing. They just burst. Now, what's inside a red blood cell, did I tell you? Oxygen, okay, but iron. So these children, even becoming adults, have this overwhelming iron in their blood. So it gets dangerous. So they require iron chelating, either medications or what we call an apheresis. And I'll go into that more. And then, of course, we have that red blood cell destruction. Mostly that infection can cause it, or it could be drugs, or it could be an immune thing going on. So what happens with anemia? Well, the problem with anemia is your vasculature likes it full of blood cells. So you don't hear those cells banging on each other in the vessels. When you see anemia, the body is like, I'm not getting the oxygen and nutrition that I need. So let me beat the heart faster to get it around. And then you're going, and it causes that turbulence, and you're going to hear a murmur in the heart, because it's just all of that flowing going through, and it's not, they're banging instead of just flowing and holding each other tight. So no oxygen, what are you going to see? You're going to see a child who's tireder, who has no energy. You're going to see them cyanotic, because red blood cells carry oxygen. And then if you're not getting nutrition and oxygen, you are going to see that growth retardation. The child's not going to be as big as they should be because they're not getting nutrition. So how do we manage anemia? Well, number one is history and physical, because there's many anemias. Tell me what's going on with you. Many a time it is just, I'm feeling tired, that, fatigue, which is the biggest symptoms of anemia. We're going to draw just a simple CBC for anemia. Now, we can go ahead and give blood and treat the symptoms, but find out what was the cause. Why are they anemic? Is it iron deficient anemia? Is it because of B12 deficiency? What is it from? Because we can replace those things instead of needing to giving blood transfusions for everything. So with anemia, what do we do? Now I'm going to tell you, with anemia, children come in and they're tired. Their H&H could be, let's say, just 7 and 21, and their body's working hard. It's going to be the elevated heart rate. So we give fluids. We give a bolus of fluids to replace that volume. But do you realize that the hemoglobin hematocrit is going to be even lower because you've diluted that intravascular space so much? So where it was 7 and 21, after a bolus of fluid, guess what? It comes down. It might be 5 and 15 now. So be aware, these children are going to need some oxygen. They need to maximize the amount of red blood cells and how many are carrying oxygen to the body, because that's what the body needs. And then we're going to minimize energy expenditure, which means bed rest. So the assessment, number one, what's the age of the child? The racial and ethnic background. Well, we know sickle cell is the African-American child, so we would think maybe sickle cell, but Mediterranean descendants is that thalassemia or Cooley's anemia, okay? So knowing background is important, and getting that history is important. What are you seeing? Has it been a progression to that being tired, etc.? And then to rule out an occult bleeding episode, we'll do a stool for occult blood. Maybe it's just a GI bleed. Maybe it's just an ulcer. Maybe it's not that anemia that we thought it was. Now, children don't like to be pinched. They need to be really prepared for the tests and things that we need to do. You know, today we've got numbing creams and sprays and distraction and all these things that we should use for children, because a child who does have iron deficient anemia or B12 deficiency or any of the other anemias are going to get frequent lab tests. So we need to not have this kid freak out every time he comes in to get a blood test. So make it as a pleasant experience as possible. So at home and in the hospital, while they're there and they're anemic, we're going to do everything to decrease that tissue oxygen needs, which means they're going to rest. We're not going to overexpend them, making them do things they shouldn't. And of course, prevent complications. So iron deficient anemia is simply an inadequate supply of dietary iron, which makes that the iron is not in the red blood cells, not carrying around. So therefore the body says, you know, I need my iron. And they say, okay, you need to rest and be tired because you don't have it. Now today, what we do to help from the very beginning of children is, if you have formula that you're giving your children, you're going to be given iron with iron formula. So it's not just plain formula, it's going to be formulas with iron. And as we get to that 6 months where we start to feed children, the first thing we start feeding them is cereals, and it's iron fortified cereals. Now, premature infants are a little bit different. They have really good formulas, a little bit higher in calories because they can't eat as much. And we might even be given some vitamin D and some infant iron by mouth. Now, adolescents, you know, you're thinking iron deficient anemia. I'm talking infants. Now I'm talking adolescents. Well, remember, they grab a snack bar and they grab 2 bottles of water and run out of the house, and they have no time to eat. Plus their body image, you know, they don't want to be fat, so they're not eating. So what happens? They don't get the iron and they become iron deficient anemia. Now, sometimes infants are given just whole milk instead of a formula. And that's what milk babies is. It means they're not getting the iron that they need. So that's what a milk baby is. So we need to give more iron to this child. Well, if they're an infant, we're going to introduce a supplement, an iron supplement, or we're going to be given some iron dextran, which is a Z-Track IM, given, once a month, once a week, whatever the physician thinks. So some sort of iron supplementation. So sickle cell anemia, you know, you've heard about this in med-surg, and you know it's the sickle cells. And what happens is the blood is going through the body, comes to a bifurcation in the vessels, and right at that bifurcation, one of the sickles crosses it, so nothing can go through to either side of the bifurcation. And then the cells pile up against each other, causing pressure, swelling, pain, and then below that, they're not getting oxygen or iron. So that is also screaming. And these cells die quickly. So it is an autorecessive disorder. And it is said that if both parents have the trait, you have a 25% of getting sickle cell anemia. So what is sickle cell anemia? Again, it's that obstruction of those red blood cells, all of that inflammation. Those cells are dying quickly. And because there's no movement of blood going somewhere, you see that local hypoxia, and you'll see cell death because you're not getting oxygen nutrition. The body that's going to say, okay, I have nothing, I'm going to die. So sickle cell anemia, there is crises that occur. There are different reasons that they have a crisis. Number one is infection. So parents are taught and children are taught, you have a fever of 100.5 or higher, you need to get or call the physician so you can be placed on antibiotics, okay? That's the number one, because infection is the big thing. You have fever, what happens? You dehydrate because you need to have more volume of fluids into you. Trauma can cause it, stress absolutely can cause it. And a big thing is dehydration. So children like to get up, go out, play outside. And I live in South Florida. It's hot here. They should be carrying a bottle of water or some sort of electrolyte drink, Pedialyte, if they're young, or Gatorade, Powerade, one of them. So how do we manage sickle cell anemia? Well, number one is we try to prevent it, and one of the ways that we prevent sickle cell anemia is to keep this child hydrated and offer frequent rest periods because they don't have enough oxygen going around. Cells are dying. And usually hemoglobin hematocrits are lower, right? So we need to rest them. And if we keep them hydrated, we're keeping those cells flowing. So they're not going to stop at that bifurcation. It's going to be able to flow down there. Now, let's say we have a sickle cell attack. You have a child, let's say the knee is hurting, it's swollen, you can see it, they're telling you in so much pain. So what do we need to do to treat this? Well, most of these are due to dehydration or those vessels being very small. So number one, start an IV and give a bolus of fluids. Fluids are a big deal in sickle cell. So we're going to give fluids, and what is that going to do? It's going to dilate those vessels, right? But also we're going to put heat on that area because it causes what? Vasodilatation. And between the fluid going in and that heat dilating, it's going to break up that sickle cell little clump there and let those cells flow. And of course, at the same time, we're starting an IV, starting those fluids, we're going to be giving pain meds because it hurts. And as I said, most of these children are with a fever. That's mostly the reason why I see them in there. They come in, whether it was stress that caused it or whatever, they have low-grade fevers, they have an elevated white count, we start antibiotics. And if their hemoglobin and hematocrit are very low, we're going to be given that blood. And it is started as soon as emergency room. So prognosis of sickle cell anemia. Well, children can grow up to be adults and live to the 50s or more if they take care of themselves and get on antibiotics as soon as they, start with a fever. That's the big thing that causes these children and becomes adults that they can't fight against it and they die from it. So making sure they get treatment as soon as possible. Bone marrow might be, a cure, but really there is no cure. So what are we going to teach our children and our parents? Well, number one, as I keep telling you, as soon as you see a fever, as soon as you see the pain, get early intervention, because as soon as we see it, we can take care of it quicker. And it's not going to be this swollen, maybe it's only this swollen. So we can prevent a lot of that pain and suffering. Now, many children from the ages of 2 months up to 5 years, they're given prophylactic penicillin, 1 pill a day. And that's to try to help the immune system so they don't get those fevers. Now, sickle cell is non-discriminate. It's going to sickle wherever it wants. And it can sickle in the brain. It can sickle in the eye. So if we are seeing headaches and there's a sickle cell child, think this is probably a sickle crisis that's going on in the brain, okay? And our goal, fluids, get it in there, break it up quick so that we don't stroke. And then, of course, we also can have it in the lungs. Probably will mimic things like a pulmonary embolus because that's what it is. It's just not moving any blood around and it's swelling. We want these kids to be normal. We want to prevent attacks, and we can do that by diligent, keeping hydrated, keeping the penicillin in once a day, and seeking treatment as soon as we see anything. So rest, hydrate, electrolytes, pain medicine, blood, and antibiotics. And that is how we treat them. As I said, prophylactic antibiotics, and then monitoring retic counts to see how is the body producing cells, how quickly, and then of course looking at it. And again, blood transfusions, what does it do? It gives cells to that child with iron and oxygen in it, which can help prevent, periods of ischemia. Now, thalassemia, as I said, is another type of illness, it's anemia, that these are affected by descendants of people living by the Mediterranean Sea. As you see the pictures of those cells, you have normal red blood cells, they're round, they bounce off of each other. Thalassemia, they're like rectangles or squares. And what the problem is they burst. So what's inside red blood cells? There's iron, right? So the big thing is that iron going out. Now there's different sort of anemias, but usually when we talk about thalassemia, we think about thalassemia major, which is Cooley's anemia. These children become adults that require frequent transfusions to survive because their body's not making appropriate cells. Also, they do splenectomies on these children so that the body's not producing these cells that are spewing iron into the system, which requires iron chelation therapy, whether it's medications or that apheresis, like I said. So usually at birth, we don't see it, okay? Those red blood cells change about 6 weeks of age. And what happens and why we diagnose it is these children become anemic, become tired, they're not eating well. And with not eating well, they're going to have failure to thrive, growth failure, and we go looking. And of course, the first thing we look at is a CBC, and then we're going to see the cells, and we're going to say, okay, so what do we do for these children? Well, we're going to give those blood transfusions to get the hemoglobin hematocrit where it needs to be because the body's not doing it, and the cells that they're producing are not good cells. And as I said, we're going to be given those iron chelating drugs like Desferal. And then what it does, it combines with the iron and then you just urinate it out. Prognosis is good if they do what they're supposed to do, get the blood transfusions the way they should. But if you can imagine, you go from a lot of blood to anemic, a lot of blood to anemic. So the body is, the heart's racing, slowing down, heart racing, slowing down, because the heart tries to compensate for no oxygen, no what's going on here. So you get heart disease with these children. You can, because I said this, one of the treatments is a splenectomy. Sometimes they're immunosuppressed children. So you're going to have some sepsis going on. They're also saying maybe bone marrow, but we're not sure about that. So what are we going to teach these children and adults and parents? Well, you need to have compliance with the transfusions and the chelation therapy. Too much iron is toxic, okay? These children will be constantly getting IV sticks. Many of them will maybe get a central port in, which would be the best thing, but make sure that these children know what's going on and, try to talk to them on their level and get them down. And again, these children are getting multiple blood transfusions. So again, you're going to have blood transfusion reactions. So make sure we're watching that. Now, aplastic anemia, there's two types. We usually talk about that it is a profound anemia and leukopenia and thrombocytopenia, which means what? Well, low hemoglobin hematocrit, you have low white count. So leukopenia is low white count. So what are you going to do as a nurse with a low white count on any patient? Well, this patient is susceptible for infections. So just basic hand washing, seriously, that is the first line, is to prevent spread of infection to that child. And then there's thrombocytopenia, which means P, platelets. Platelets are low. So hemoglobin hematocrit are low, white count is low, and your platelets are low. There is another type that just have RBCs, but the other stuff is normal. But when we usually talk aplastic anemia, is the pancopenia. That's the one that we're talking about. So how do we treat aplastic anemia? Well, we need to put them on some sort of immunosuppressive therapy. Again, bone marrow transplant. And a lot of the treatment that we do on aplastic anemia is very similar to what we do for leukemia. Now we're going to talk about problems with bleeding. hemostasis, clotting problems, etc., platelets, what's going on. Now, when you think of bleeding problems, you think of hemophilia, right? Hemophilia is an inheritable X-linked recessive, which means mom has that gene that is passed off onto her children. Now, once you know you have hemophilia, they're going to figure out where you're seeing these bleeding issues going on. We're going to look at to see what clotting factor is missing, because you need all the clotting factors not to bleed. So in classic, you think of hemophilia, you think it's deficient just factor 8. That's the most common. But there is factor 9, which is called Christmas disease. Again, it's just another factor you don't have, which causes bleeding. And then we determined there's this von Villebron disease. One of the research doctors named von Villebron found another factor which helps in bleeding coagulopathy. And he found out that it's not just factor 8, it's 2 different clotting problems, von Villebron and factor 8. So how do you know you have hemophilia? Well, these children tend to bleed, as in you get a cut, they bleed, they don't stop. One of the hardest things is children are children. They get up, they run around, they fall down. Let's say they fell down, banged their knee really hard on a rock, and now they're bleeding inside their joint, which is called hemarthrosis. What does blood do to that joint? Well, it destroys it after time if you don't treat it properly. So these children could become in a wheelchair if we don't treat these properly. You're also going to see, of course, bruising. I mean, bruising is obvious, and of course, obvious bleeding, and then in the joints. So again, it's X-linked, inherited, and what we will see on a lab. Well, you're going to see that low level of whatever that clotting factor was, whether it's 8 or 9, okay? And then you're going to see a prolonged PTT. We see prolonged PTTs with heparin usage, right? We give heparin, we monitor APTTs, right? Same thing with hemophilia, but your platelets are normal, which is different than aplastic anemia. So how do we treat hemophilia? Well, you have a child that we know they're missing a clotting factor, and what they'll do is these home infusions. They are like these children that keep home. You don't have to have them come in a hospital. And actually, I have seen a father come into the hospital emergency room whose kid fell down and actually fell on his knee, and it was big and it was ecchymotic and swollen and painful, and couldn't get a hold of his hematologist. So came into the ER to say, do I give the factor or not? I don't know. So he came in, our physician said, yes, give it. So I was the nurse, and actually I had an orientee with me. And I said, okay, Dad said, please, can I give it to him? I'm used to it. And I said to the kid, you're okay with that? He said, oh yeah, me and Dad are good at this. I watched that father and the son look at which vein he was going to use. The son helped the father, held the butterfly in place. The father washed his hands, mixed it up, put it in a syringe, flushed the tubing, and put it in the way he should. Better than most nurses. And my orientee was like, holy crapola. I said, that was amazing. And he only came in because he didn't know if he should give it or not. So, you know, it can be given at home very well. Now, there are some type of moderate, mild sort of hemophilia that you can do this nasal spray. That'd be nice, but not many of them are that. And then, of course, there's aminocaproic acid that is sometimes added on. Now, hemophilia, you can live a normal life as long as you monitor these bleeding episodes and prevent that bleeding into joints. Because if you keep it in the joints and it keeps continuing bleeding, falling down the knees, hips, you're going to have necrosis of those joint sacs, and you're going to end up in a wheelchair. So as long as they're very proactive, giving themselves their factors when they need it, they do a really good life. There is gene therapy. They're working on it. It's still not there yet. So our goal, prevent bleeding as nurses, keeping a safe environment. making sure there's not trip hazards or anything in their rooms if they're admitted to the hospital. And then think of dental hygiene. Remember, they can bleed in their gums too. So good, soft toothbrush, brushing their teeth. Just like we would if we had a sprained ankle, we're going to rice. We're going to rest whatever has been, hit and bleeding. We're going to rest it. We're going to ice it to constrict those vessels to prevent bleeding. We're going to put an ACE bandage, compress it. It's like a finger on a bleeding anything. We'll hope it, and then elevate it. And that really, really helps these children prevent those crippling episodes. Now, immune thrombocytopenia, idiopathic thrombocytopenia purpura, which is ITP. Remember, P is all about platelets. So what do you see in these children? They don't have platelets. The platelets could be 10 or 15,000. You don't have platelets, you're going to bleed. So what do these children usually come in with? Well, they usually come in because they're either having nosebleeds or they're having bruising, or they see this sort of petechiae, sort of purplish little tiny little rash. Most of those I've seen actually on the legs. And they're like, well, the kid doesn't go outside. I don't know why he's bruising. I don't know why he has a rash. He hasn't had medicines. And it's usually that and nosebleeds that will figure out what's going on. So what is one of those things that can cause it? Well, we do have some information that says that if you've had an upper respiratory infection or some sort of infection, you can decrease your platelet counts and have this idiopathic thrombocytopenia purpura. Now, it can be an acute stage where we can cure it, or if it's lasting over 12 months, usually we're going to say that it's going to be chronic. So how do we treat ITP? Well, we give IV immunoglobulins, IVIG, and we also give anti-D antibodies. And sometimes, if you look way at the bottom, corticosteroids. So what are we going to do as a nurse? How are we going to treat these patients? Well, I'm telling you, they don't have platelets, they bleed. So we're going to be on bleeding precautions, soft toothbrushes. We're going to be monitoring their urine and their stools and their skin and looking for bleeding. If they're in the hospital, we're going to be monitoring those blood counts, and needed, we're going to give corticosteroids. Now, I said we're going to mention DIC. I'm not going to go in it a lot because it's so confusing, but basically what happens, it causes a problem with the coagulation cascade. So they have a lot of thrombin, which causes clotting in the body. So it just keeps releasing due to this sepsis or acidosis or something's going on there. So what we give is heparin, and a lot of times we're going to give blood products for these children. So as soon as we can figure it out, what is the cause? If it's sepsis, we're going to treat sepsis very aggressively. And again, platelets, fresh frozen plasma, heparin are all being given to this child to help keep the blood thin enough and moving through the organs. And you heard me mention about epistaxis. It's one of those things that when they come in and they have epistaxis and it's more than once, maybe it's 2 or 3 times this month, we're going to be drawing blood and we're going to be checking why, because something's going on. But how do you treat a nosebleed? And what are you going to teach your patients? Well, number one, children see blood, especially those, older toddlers and preschooler. They see blood, it's bleeding out, they're gonna die. So keep them calm. Put them on your lap, give them a hug, take your fingers and pinch their nose and have them sit forward. Now, if after 10 minutes they're still bleeding, you need to get them to the physician, whether it's the office, whether it's the urgent care, or to the emergency room. Now let's talk about a little bit of an immune problem. HIV AIDS is a disease that it's a virus, and we know that mothers can pass it on to their newborn children. Now, I want you to know that just because they passed it on, Not every child has HIV. There is a chance for that child, that infant, to become a child without HIV. I've seen triplets where HIV mom actually turned to AIDS, had 2 children convert and they were not HIV, and one was HIV. So how do we do that? Well, number one, if the parent, the mother, gets this heart therapy, which is basically a highly active antiretroviral therapy, about 22 weeks into pregnancy, and we're going to give that up till birth. At birth, we are going to start the child's own antiviral therapy. Why do we start antiviral therapy that quick? It's because we want to boost that newborn's immune system. And boosting that immune system will keep the HIV from sticking there and staying there. So the prognosis, as I said, for children, it can be, they can get it or not. But the goal is, as a newborn, to boost their immune system, and it can help the child to not convert into HIV. Now, pneumocystic pneumonia, pneumocystic carny pneumonia, PCP, is the most common pneumonia infection or opportunist infection that you see with HIV. And this is, of course, with respiratory. You also have yeast, which is another one that can occur. The baby's tongues can get white. And of course, we're just going to be treating it. It's hard to treat these children, in these big nurseries, because we have to keep that confidentiality to the other parents in the room, because they hear, oh my God, the baby's HIV, it's like the baby has this, horrible disease. You're not touching that child. It's okay. You'll be fine. So treatment of hematologic and immunologic diseases is a lot of just giving that blood back to the child, whether it is packed red blood cells, whether it's platelets, so we need to know about giving blood transfusions. Always follow whatever the hospital's protocol is. Usually it's 2 nurses check blood, they do vital signs, start the blood. 15 minutes later, take a set of vital signs, and every hour thereafter. If you have anything that's showing you reaction, and most of the times I don't see a rash or anaphylactic thing, it's all of a sudden they spike a temp of 101. That is a sign of a reaction. So what do you do first? Turn it off. That's number one. Now, apheresis, I've mentioned that with the iron, and you could pull off different things in the blood. And nurses, RNs at the facility I worked, used to run the apheresis machine. And it's just at the bedside, and it pulls off what you don't want in there and keeps what you need. So if both parents have sickle cell trait, what's the chance that each of their children will have sickle cell? Anybody? Anybody?
Is it B?
A.
It's
100%.
It's 25%. Okay. So let's talk about some neoplastic disorders. Cancer. The leading cause of death from disease in children past infancy is neoplastic disorders. Over half are blood or blood-forming organs like leukemias and lymphomas. Well, leukemia is where you're producing white blood cells which don't work. You have 2 types. You have acute lymphocytic leukemia, ALL, and then you have AML. Now, if you were to get cancer, you want ALL. It's easier to treat. AML is more difficult, okay? Usually it takes multiple treatments in order for that to go away. You're going to see this in boys greater than 1, ages 2 to 5. So it's very hard for a parent who all of a sudden sees their child bruising, bone pain, being tired, and they're going to go, all right, let me take him to the doctor. they do the CBC looking for iron deficient anemia, and it comes out with leukemia. Very hard for these parents, and being a nurse with these parents, it's very difficult. But survivability is great today. They do survive as long as they follow the treatment. So what is the diagnosis of leukemia? It's basically an unrestricted proliferation of immature white blood cells in a blood forming tissue. That means there's no real immune system. You know, there's no white blood cells. How are you fighting infections? These children get infections extremely easy. So what are you going to see with leukemia? Well, I had a next door neighbor who went to the ER complaining of being tired, was having pain in her bones, especially one of her knees, and had bruising, and it wasn't normal for her. They did a CBC and they found her white count 0.1. And we know white count should be at least 5 or higher, okay? And didn't have it. So she was diagnosed. So they saw immature leukocytes, and then her hemoglobin hematocrit were really low. They do bone marrows in order to look at the cells and find out, is it AML or is it ALL? Now, once we determine children have leukemia, they do put these nice central ports in, so they're not going to be stuck all the time in their hands and the arms. It's just putting numbing cream on the area. It's in the chest somewhere where that port will be, and they start leukemia, the chemotherapy. Now, the initial stage of giving chemotherapy is called induction therapy. Now, for the 4 to 6 weeks, they hit these children with 2, 3 different types of chemotherapy. And the goal is remission after 6 weeks. But because that's quick, there's a couple little cells left, they're going to be going into more different types of therapy. They're going to put it intrathecally. They're going to do intensification therapy and maintenance to get rid of those little cells that it didn't catch. But induction is the goal of remission. Now, leukemia, one of the cures is a hematopoietic stem cell transplantations. Now, this is pretty cool when you're talking about this. You don't have to match them. You can have donors that are not even related to you, but the best one is the siblings, okay? Siblings is the best, and that's what we call the allogenic ones, okay? Now, there are times where you have that cord blood saved and you have the patient's own, but actually the siblings is actually better. But when you give these transplants, you can have it's called a graft versus host disease. I've seen a sickle cell child get one of these, and she had what we called a graft versus host, and it was her face felt like it was burning and falling off, and it was creating so much pain, and that's how she presented. And of course, it can affect your organs. So leukemia, what are we going to do? Well, these children are in and out of the hospital. These children are going to be kept at home. They're immunosuppressed. You know, they are going to be going through a lot. So again, prepare the children and the family for what's going to happen. As I said, there is bone pain. There is pain that is with that. So make sure that we take care of that pain. And of course, preventing any complications, infection, hemorrhage, anemia. And nurses, you know, we need to be careful with those chemotherapy agents. You know, today in pediatric oncology, there are many hospitals that are offering $20,000 sign-on bonuses. That's how desirable it is to find nurses to work pediatric oncology. And you're going to say, I can't do that. Well, not every child lives in any diagnosis or any adult. It's just what you gave that kid while they were alive. And it can be very rewarding. So how do we figure out prognosis of leukemia? Well, what was their initial white count? Was it 0.01 or is it 0.001? You know, depends. Were there 10 or 100 cells in there? Also, how old was the kid? And then was it ALL or AML? And male and female does make a difference. And what type blood do they have? Are they a normal, A positive, O positive, or are they a very rare blood type? Because these children will be getting blood. And now we're going to go into the other cancers. So how do we treat cancer? Well, usually surgery, chemo, and radiation. Those are basically what we use. So how do we know a child might have cancer and start to look where it's going to be? Well, as I said, that's pain, fever, bruising, petechiae, bleeding somewhere, that lethargy, weight loss is always one of those, and anemia. Sometimes it's vision. That is not as much as the other. So how do we treat a child who has cancer? Well, of course, as I said, they have this really low white counts. They're immunosuppressed. And one of the things we look at to work with these children is a neutrophil count. Well, neutrophil count is going to tell you how are they able to fight infections. And if they're a neutrophil count 500 or less, these children you need to be extremely careful with. And I'm telling you, the first thing is just hand washing. Hand washing is so important. And then, of course, if you have a cold, a mask, or whatever, but hand washing is number one. And making sure that we do start those broad spectrum antibiotics as soon as possible. Hemorrhage is happening because the platelets are low, hemoglobin hematocrit's low. So it is giving transfusions, giving platelets, and then of course, teaching these children they can't be out there riding a skateboard or a bike and falling off, because if they fall, they're going to bleed, and that can cause some more complications. Nausea, vomiting. Well, we're going to be treating 30 minutes before we give chemo. We want to prevent them from having nausea and vomiting. And this is a change in practice since I became a nurse. You had to vomit before you could give an anti-nausea when I first started nursing. Today, no, we're preventing what we know is going to happen. And they are using synthetic cannabinoids on children, and actually it works pretty good. These children are not going to want to eat. They don't feel well. Sometimes their mouths are swollen and, they just don't want to. But remember, nutrition, nutrition, nutrition. Without nutrition, how are they going to fight? How are they going to have that energy? How are they going to, grow, et cetera, fight these infections? So what are we going to do as nurses? Well, we're going to monitor what they're eating and their nutritional status. And we can monitor that very closely by just a simple height and weight, and of course, some blood tests that we can do. Children with cancer need a high protein, high calorie, full fat, which means give me a load of everything, because they're not going to eat as much. We need to give them per bite more bang for the buck. As I said, sometimes mucosal ear ulcerations, it could be from mouth to anus. That means the whole GI tract could be upset. So what are we going to do? Well, we're going to, because we eat and they don't feel well, we're going to give them those bland, moist, soft foods, brushing their teeth with that soft toothbrush. And sometimes we do mouthwashes. Now, you would say if you have pain in your mouth and all these ulcerations, just numb it with lidocaine all the time. But remember, there is an overdose of lidocaine. So we don't like to do it. Plus, they tend to choke because they can't swallow because it's numb. You can have neurological problems. So they don't want these children bearing down to be able to move their bowels. So stool softeners, because if you bear down and you push, you can have a stroke, okay? We are going to give them their pain medicine as they need, and of course, watching their intake. They can have hemorrhagic cystitis. Again, we're going to be watching for bleeding, because bleeding is part of it. Low platelets, low hemoglobin, hematocrit. And then, of course, children on chemo, adults on chemo can lose their hair. And many of these children, you're going to see the hair just clumping out. I've seen many a father and brothers will shave their head to be with their kids. You know, what I used to do with these children is I used to have ribbons and I make it into little bows and put little bows on their hair. And I would wear one in my hair so we'd have matching ones. And it would be when I came on, what color are we going to wear today? And made it more of an event than I don't have hair. We do give a lot of steroids when we're talking about chemo. We're talking about cancer. So remember, with using steroids, we have to be careful of these big doses and Cushing syndrome. You know, Cushing syndrome is that big round face. You know, it is those skinny, usually little arms and legs and extra hair. All of these things. And of course, there's going to be problems with salt intake and fluid retention. So a lot of these tests we do under sedation, but remember there's that normal test that we do, those blood tests, etc., that, you know, we don't have that. But using pain medicine, you know, numbing, topical numbing, and like for going into a bone biopsy, numbing it deeper so that these children have less pain, because they're not just going to get one, they're going to get multiple. And if we hurt them the first time, guess what? They're not going to want it a second, third, or fourth time. So pain medicine is just not those opioids, just not morphine. It's just not that. Remember, we have Tylenol and Motrin, which work very well, also elevating them, distracting them, hot, cold, all those positionings, all those things can help children with pain. So making sure that we use every resource available. You know, Nicholas Children, where I came from, had a child life team, which are employees that were actually gone to college for bachelor and masters to learn how to play with children in their developmental ages. And they'll come in and play with these kids and distract them, you know, when they're not feeling that well. Now, lymphomas is something to do with the lymph nodes, and there's two different types, Hodgkin's and non-Hodgkin's. Now, Hodgkin's lymphoma is the lymph nodes. And what you're going to see is these big nodes. It's usually from the head up, you know, shoulders up, and they're big and they look like they hurt. They're painless. That is the clue that this is Hodgkin's lymphoma. You're going to see all the signs and symptoms of the cancer, of the fever, anorexia, weight loss, yes, but these lymph nodes are going to tell you, you know, this is Hodgkin's. So what do? We're going to do that CBC and we're going to look at it and we're going to do a biopsy of that lymph node. And when we get the biopsy back, if it is Hodgkin's lymphoma, you're going to see the presence of Sternberg-Reed cells. So what do? Well, if it's one lymph node, we're going to do radiation. We're going to do chemo or both together. Long-term survival is great, okay? It does require a lot of procedures again, so always, you know, prepare your child for what's going to go on. And a lot of times with radiation, depending on where you're giving it, there is a high risk of infertility. Now, non-Hodgkin's is more diffuse. You don't see it like a big node hanging out. You're going to see, you know, all of the same symptoms, you know, the weight loss, fever, anorexia, but you're not going to see those lymph nodes. So what they'll do with this one is, of course, do CBC. They're going to find it. And what they're going to do is a bone marrow to see if we find those cells in there. And that's that biopsy that we're going to be looking at where they come from. So this child's going to get those aggressive radiation and chemo. And again, we're going to have a decent result from it, but it takes a while to diagnose these children because they don't have that big node. So they have to keep looking for what's going on. Now, brain tumors. Brain tumors, all of a sudden the child starts vomiting and starts not eating and starts headaches. Now, how do we start to think it's a brain tumor and not just a headache? Well, if you have a little headache and it gets progressively worse, more frequent, you start thinking. And then that nausea and vomiting, not related to food at all. And you're going to see it get progressively worse and worse. So you do the CAT scan, you find it, the MRI. All right, we have a tumor in the brain. So how do we treat it? Well, we're going to do radiation, chemo, and surgery and remove that tumor. Postoperatively, nurses have a great chore because where do we position these children? There's a hole now. I'm missing something in that brain where the tumor was. Do we position them on it, off of it, head of the bed up, medium, or down? These are things that nurses have to be careful with. And then turning and positioning, how are we going to do that? And to be safe for these children. So what are we going to do? We are going to these children again. They're going to come out. They're going to have these big bandages on their head. They're going to have drains coming out. Sometimes, intracranial monitoring. The older children know what's going on. So prepare them for it. As I said, where are you going to position them? And when you're talking about brain intake output, strict INO, because overabundance of fluid can cause increased intracranial pressure, and we don't want that. And of course, keep the kids comfortable, keep them being the best they can be, and be there for those parents. Now, neuroblastoma, I mentioned, it is a tumor that you usually find in the abdomen. And it's a small tumor that gets larger, that usually on one side, and then it grows over. So it crosses the midline, as it's called. But once we see that tumor in the abdomen, problem, it's usually already metastasized to the brain. Sometimes we don't see it in the abdomen. It's not as pronounced as this picture I have here, but you're going to see those edema, and you're going to see the eyes popping out, an ecchymotic area around the eyes and face. That's when it's already pretty too far gone. Luckily, it is not a common cancer at all. So again, these children are going to be going through chemo and radiation and surgery. So make sure that we are preparing them completely for it. And then another tumor that we're going to look at is an osteosarcoma, which is a bone tumor. Now, the femur bone is the common place for an osteosarcoma. It is very cancerous, and it's usually males and adolescents. So usually it will start with, you've got pain in your leg, that you thought it was because of sports, you're exercising, and then you keep, ignoring it, and it gets worse and worse. And then finally you go in for treatment, and what they'll do is an X-ray, then a CAT scan, and MRI, and they'll see this fuzzy haze on the femur bone. You'll see that anemia, that weight loss, and again, infections you're going to see in these children. Now, what do we do for these children? Now, years ago, we used to just cut the whole leg off because you can't replace the femur bone. The femur bone is there. It connects to the hip. So once you remove it, it's gone. But today they're taking the lower leg and they're attaching it up into the hip. And why do they do that? Because it's a place to attach a prosthesis. So these children can be more normal. They can have that motor to be able to get around. They do surgery, they do chemo, and what we want to do most of all is to save that limb, which is called a limb salvage. Now, Wilms tumor is a common tumor of the kidneys, and it's usually boys ages 3 to 5, African American. Now, I have a story about right after the Haitian, the earthquake that hit Haiti several years back. Our hospital went there and we found this little 3-year-old boy which had a Wilms tumor. Well, they had some religious group somehow get him in a plane with the records, which are all in French. And this religious group picked him up from the airport and they were told, bring him directly into the emergency room to be treated. Well, I didn't know about it. I didn't know what was going on, and I can't read French, so I didn't know what was happening, so I had to do an assessment. So I did the height, I did the weight, I did the vital signs, I did a neuro check, I listened to the breath sounds, and then I went to listen to the abdomen, and on the left lower quadrant, I found a softball, at least, size tumor. And I don't even know why I knew it was a Wilms tumor. It's one of those pieces of information that all of a sudden, that's a Wilms tumor. And I knew, number one, my priority, do not palpate that abdomen anymore. Because what happens is the tumor breaks off and it will metastasize within that abdominal cavity. So we don't want to do that. We do either an ultrasound or a CAT scan, and we find out what's going on. Now, they have a great success rate. They do surgery, they do chemotherapy, and they get it out, and these children do okay. We need to monitor these children post-operatively. This was a kidney tumor, so we're monitoring their intake and output. And it was really occupying space in the GI cavity. So be very careful of monitoring bowels, making sure that it is working properly. And again, do not palpate that tumor. That's the big thing. Rhabdomyosarcoma is something from the tissue, from the muscles. You'll see it in the eyes, the nose, the ears, and it's a tumor. And it might just be the earache that's chronic. And then they find out there is a tumor in there and they have to remove it. Retinoblastoma. Have you ever had an animal in your backyard at night? You turn on the light and you see white eyes shining. It's that cat's eye reflex, it's called, or that whitish glow. You will see the child. I've seen one 8-month-old child have it, and that one eye had that white, and it was like, that's not right. And that's what clued us into what was going on, because it comes from, the retina, and they need to remove that eye. And what they do is, first they'll take radiation. And if you notice that little blue little spots there, that marking, these are little clues to the radiation therapy department where to direct radiation. So never wash them off, okay? Leave them there for them. And then what they do is, after radiation and chemo, they'll remove the eye. And what's pretty neat is today we've got these fake eyes that you can put in that you wouldn't even know, unless you really look, that this child had an eye removed. Then there's germ cell tumors. It's a testicular tumor. I had an 18-year-old boy come into the emergency room complaining of scrotal pain, testicular pain. And we did a whole big, history on it. I was with another nurse in there, and the other nurse, did a physical exam. And when he walked out to go to wait to get to a room, she said that his testicles were the size of a softball. So what they did was an ultrasound, found it was a tumor. Then they did an x-ray of the chest and abdomen. He already metastasized all over his body. This 18-year-old boy was dead in 3 months because he waited for treatment. So just like we do self-exams on our breasts, men need to do testicular exams to make sure there's no tumors, because he said he found it a month ago. I'm sure it was a couple months more than that, but early treatment could have saved that kid. Liver tumors, we have multiple lobes of our liver, so we can remove a piece, and we know liver transplants do actually work pretty good. So childhood cancer survival, the 5-year survival rate, 80%. I'm sure it's more than that now, because there's so many new things that we're doing that really, really help. And childhood cancer is not always a death sentence. It can be treated today. So our goal in every kid who had cancer is them posting on Facebook this little sign that says cancer free, right? So any questions? A lot of heavy stuff there, huh? Who wants to win the Kahoots today? Ashley, yeah? Cody? Sandra? Rosa? Brent, you're going to win today. There you are. I know you're looking. Are you other guys still here? Danica? Alexandria? Jessica? Are you all here?
I'm here.
Yes.
Janaya? Jayo?
Here.
Jillian? You half asleep on me yet?
I'm here.
All right, just don't go to sleep on me. Here we go. Let's play our game. All right, let's get going.
Hold on. Oh, never mind.
Which statement best describes a neuroblastoma? Remember that little baby with a picture with that big abdomen? Cody, did you get the code? 212-8855. So neuroblastoma, remember, we find this tumor in the abdomen, but by the time we find this bulge in the abdomen, it's already to the brain. So diagnosis is made after it's already metastasized. Cody, you in?
My internet's being slow. I have like basically like dial up because I live in the boonies, so I'm trying to come up.
Okay. All right, just follow with us. It's all right. What is priority treatment for a newborn of an HIV positive mother? What did I tell you we want to do for these newborns? Because remember, they don't have the symptoms of HIV. And how do we prevent these infants from getting HIV? When I first heard that we could, what we call zero convert these children, I was like, really? And I've seen it happen. So what we want to do is improve that infant's immune system to this virus so they can fight it and get rid of it. Now, Sandra's up top. What are symptoms of sickle cell anemia? So when you see hands, feet, knees, shoulders, anything swelling, but the pain, and remember, it can happen in the eyes. So vision problems, even headache. And if we don't treat it and we don't let blood flow, you're not getting that nutrition and oxygen. You're going to have that delay in growth too. Sickle cell anemia affects which cells? And it's absolutely red blood cells, nothing else. Put it there for a reason, that question. What kind of hemoglobin and hematocrit would someone with sickle cell have, and why? What do we know about sickle cells? So remember, when sickle cell kids come into the ER, I've never seen a hemoglobin hematocrit greater than 7 and 21. They're usually 6 and 5. I've seen them mostly there. So their hemoglobin hematocrits are lower. And why? Sickle cells die quickly. So that's why. And now Sandra's on fire. What is the treatment for sickle cell anemia? So first of all, we want to dilate those vessels so the blood can flow. We're going to give blood transfusions, medications, whether pain or antibiotics, and then bone marrow is the treatment if we get to that point. Aplastic anemia includes a depression of which blood cells? Which one did I tell you is the most popular and usually what we will consider aplastic anemia? And our treatment, similar to what we do for leukemia. Red blood cells, white blood cells, and platelets are all depressed. So these children are prone to bleeding, right? When we talk about platelets and RBCs, and they're also immunosuppressed. Their white blood cells are also low. So they're going to get infections. Now, Cody's on fire. She's in. Good. Most common type of anemia is so most common is iron deficient anemia. Good job. What causes pernicious anemia? Intrinsic factor, pernicious. Nutritional problem. Replace the nutrition, you're good. Just like iron deficient anemia, give iron to the kid. So it's a B12 deficiency. Good. What symptom is the single most common symptom of anemia? I mean, if you look at this picture, there's all sorts of things it could be, but we know fatigue is usually what gets them into to the physician to check out, why are you so tired? Good job. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for what? Remember, beta thalassemia, that's those square shells that just burst. Treatment is blood transfusions. Mediterranean people. So our big thing is when those cells are bursting, there's iron inside those cells, and it goes into the blood system and it becomes toxic. They need some iron chelation therapy, whether it is a medication or an apheresis. So big thing, chronic overload of iron. What lab values will you see with hemophilia? So you're going to see the PTT prolonged, just like heparin, PTT long, but the PT and platelets are normal. So that is hemophilia. They're missing a factor of some sort, whether it's 8, whether it's 9, whether it's 1 Villebrons. What is thrombocytopenia? Idiopathic thrombocytopenia purpura. What does P mean? So P, platelets, decreased platelets, not enough platelets, you're gonna bleed. You're gonna see so many different things. Usually that nosebleed's what brings them in. Thrombocytopenia can cause the following symptoms. And remember, it follows an upper respiratory infection. It can be acute or chronic. After 12 months, they consider it chronic. But you'll see that little purplish rash, and you'll see bleeding, as in bruising, and the nosebleeds. A multi-select. Child with hemophilia has fallen down, the knee is swollen and painful. Treatment would include what? How do you treat bruising? That blood is going into the joint and it can destroy that joint sac. We don't want these kids to be in wheelchairs because we've killed the joints. So what do? So we want to do things to stop bleeding. So we elevate it, we put cold packs on it. Hot will increase bleeding, and we're not going to do any movement of that need to keep it bleeding. We're going to do rice, we're going to rest, we're going to ice, we're going to contain it with usually a compression something, and we're going to elevate it, just like a sprained ankle. What is the nursing priority action for a suspected blood transfusion reaction? What do? Priority. Stop it. Good job. A child is admitted with neutropenia. Which nursing action takes priority? Well, what is neutropenia?
Deficient white blood cell count. My baby actually has it. She has chronic neutropenia of childhood. I thought she had leukemia, but thank God that's not what it is.
Oh my goodness. So it's strict hand washing is the best thing for these kids. And of course, if you're sick, to protect the kid from it. But neutropenia, they say it's 500 or less would be the blood count that you'd be the most concerned. Usually it's like 1,200 to 2,000, usually, depending on your lab.
Kaylee's normally stays around 2%.
Which symptoms would a healthcare professional expect to see with a child with leukemia? Well, remember my neighbor who went into the ER because of symptoms. What symptoms did she have that I told you about? By the way, this girl now has a PhD in psychology and completely, transformed after that. She went in because what? She was bruising, she was tired, and she had pain in her leg and her knee. And that was the symptoms you usually see with leukemia. Your child with ALL has recent lab results and the platelet counts are 10,000. What are you going to do? What does that mean to you? Leukemia, and she has platelets of 10,000. It's not abnormal to see that either. So you're going to place them on bleeding precautions. Remember, platelet count should be 100,000 or more. That's like the lowest is 100,000. 10,000 is extremely low, and we'll be concerned about bleeding. No IM injections. We are going to be watching for bleeding and monitoring that CBC. And Cody's still on fire. Multi-select. A child is placed on bleeding precautions for ITP. What interventions would the nurse do? Basically just said it, almost. So no injections. We're going to monitor the CBC, look for treatment. And remember, ITP, I don't need fluids. Fluids are going to do nothing for this kid. It's not a block up in the intravascularly, but we're going to treat with corticosteroids. That's the treatment here. That's one concept students are chronically missing. Sickle cell, you give fluids. ITP, it's just bleeding precautions, and we're going to give corticosteroids if needed, okay? That's the difference there. Child with Wilms tumor, what action by a nursing student causes the faculty member to intervene? Well, what did I tell you about Wilms tumor? And the first thing I thought of when I found that kid from Haiti. So you're not going to palpate that abdomen at all because that big tumor is fragile and little pieces could break off. And now you've put pieces of this tumor within the abdominal cavity and it can metastasize. You don't want to do that. Cancer of the body's blood-forming tissues, including bone marrow, is called what? Most common. of all cancers. And it is leukemia. Good job. All of the following are true concerning a neuroblastoma, except it is not common, okay? It's a lump in the abdomen that crosses the midline. It's off the adrenal glands many times. And sometimes you see that tumor in the brain, you'll see that bruising or the exophthalmos going on. So thank God it is not common at all. I've never seen one of those. Most common clinical manifestation of a retinoblastoma, the retina in the eye. What are you going to see? And it's called that cat's eye reflex. They have that little whiteness like you would see with a cat out in the field in the middle of the dark, and you turn a light on and you see that white glow. Could be a deer, could be a bear, could be anything out there, a dog. A goal of surgery for a child with osteosarcoma is, well, where is a common site of osteosarcoma? I think the picture shows you it is the femur. So what's your goal? The best possible thing to do is to salvage that limb, and that's a place where you can put a prosthesis, okay? You're gonna remove that femur bone out of there completely because you don't want any of that tumor there. And then sometimes you can't salvage a limb, then you have to take off the whole leg. But our goal is to salvage the limb, keep something there for that child to have prosthesis. Immunizations causes autism, yes or no? Absolutely not. It was a false research thing that came out, and the physician who published that doesn't have a license anymore because it was false. A child is complaining about those skin markings for radiation therapy, should be told what? So those markings are for the radiation team. They know exactly where to put the radiation next time, so leave them alone. Brent's on fire now. A multi-select. Nursing care of a patient with immune thrombocytopenia purpura. Good job, guys. That made me proud of you. No IM injections, monitor CBC, corticosteroids, IV fluids have nothing to do with ITP. We give that for sickle cell anemia to dilate vessels. There's not vessels occluded here. Good job. When distraction is used, it helps what? You know, my child life team. So it's everything. You know, when you're distracted, you watch TV, you play a game, you listen to music, whatever, it puts your focus away from the pain, and it really helps a child deal with what they're going through. What assessment question needs to be asked with a child with possible rheumatic fever? I'm going to hit you with some stuff from last week just to see if you remember. So rheumatic fever is due to a not or undertreated strep infection, and that will clue them into, let's look for rheumatic fever. And Brent's still on fire. Signs and symptoms of asthma. Again, another question from last week. Coughing, shortness of breath, tight chest tightness. You're going to hear wheezing, and remember, prolonged expiratory phase because you're trying to get the air out. Goes in, but it's hard to come out. A multi-select. An absolute contraindication for nasotracheal suction include which of the following? I mean, when shouldn't you not look in the mouth, stick anything in the mouth? We discussed these again last week. And that is epiglottitis and croup, because it's already a swelling of the upper airway. So if you go in there and manipulate it more, it's going to swell more, and then maybe your airway is completely gone now. Iron dextran is given via which route? We use that for iron deficient anemia, sometimes adults, sometimes children. And it's given IM using Z-Track. And the reason why Z-Track is because, number one, it stains the skin and it burns. So I call it, you pull back the skin, you give it, and you close the skin. I call a lock and load injection because then it can't get out. It was my first injection I ever gave, was an iron Z-Track injection. I mean, give me the hardest one to start with. I'll never forget it. What cancer may present with painless, firm, and enlarged cervical nodes? Keyword here is painless. And that is Hodgkin's lymphoma. Remember that big neck sort of lymph node hanging out there? You'd think it hurt? Not at all. And that will clue you into maybe Hodgkin's. Thalassemia major is treated primarily with what? Remember, rectangular shaped cells that burst, spewing iron into the system, and it can be toxic. So how do we treat it? Blood transfusions is the only treatment for this child, and who becomes adults, hopefully. A multi-select. What are opportunistic infections of HIV? I did mention some. We have yeast and pneumocystic pneumonia. Both of those are those things. If you think of HIV, those are two things. Actually, we are proactive and try to treat them before we get them. A multi-select. Treatment of osteosarcoma includes what? Amputation, chemo, and salvage the limb. Stem cell transplant has nothing to do with osteosarcoma. You got to get rid of that cancer in there. So, and you give chemo just to make sure that you got it all. Who are the best donors for a bone marrow transplant? A hematopoietic stem cell transplant, bone marrow transplant. And it is siblings. Remember those words, allogenic and autologous. Now I think autologous is automatically it's mine, and allogenic is siblings. That's how I remember auto and allo. What is the most common opportunistic infection for children with HIV? Most common. And that is PCP pneumonia. What would you consider to be neutropenia or a low neutrophil count in children? We're discussing that with Cody before. Thank you for sharing that, Cody. So it's less than 500 is what you'll see. And then how are we as nurses going to treat that within a hospital? Hand washing is the best thing. And Brent's still up top. A primary characteristic of a brain tumor is what? What did I tell you about brain tumors? Remember, you start with a headache, it's there, and then it gets worse and worse, more frequent, more frequent. Vomiting has nothing to do with eating, and it becomes worse and worse. So it's progression or worsening symptoms as time goes on. And last question. A child is receiving the induction of chemotherapy. What does that mean? What's induction? What did I tell you the specific thing about that is? And it's that initial intensive chemo, usually the first 4 to 6 weeks, could be multiple chemotherapy agents, and the goal is remission. And then the other stages are just to take care of those cells that are missing, and then, you know, prophylactically treating it just to ensure that the cancer is gone. Let's see how we did. Number 3. Cody, good job, Cody. Got in just in time. Number 2. Sandra, good job, Sandra. And number 1, I called it, Brent. He likes to win. Number 4, Jess and Ms. Gibbs. What I'd like you to do is sign your attendance attestations so that it's done. Remember, I am doing a review tomorrow at 2 p.m. I will record it, and I'll post it up in the same announcement that you have already with Professor Morris's. Any questions at all by anybody?
Yeah.
Take care, guys. Thanks for a
Thank
great class.
you.